I'm Peggy Peck, MedPage Today, reporting from the American Heart Association Scientific Sessions in New Orleans. Rosiglitazone, a controversial type 2 diabetes drug, failed to meet the primary endpoint in the long-awaited approach IVUS results, as we hear here.
Thiazolidine diones, or TZDs, rosiglitazone and pioglitazone, do things that one might think could affect the progression of coronary artery disease. These include that they do improve glycemic control. They lower blood pressure a small degree, usually 2 to 3 millimeters in most trials. They are powerful anti-inflammatory drugs. Notably, they produce a decrease in CRP on the average of 20 to 40%, even on maximal statin therapies. They have variable effects on the lipid profile. There are small differences between the drugs, mostly associated such that they both raise HDL and lower triglycerides. They've both been shown to improve endothelial function, and both of them, in different trials of different sizes, have been shown to reduce the progression of carotid IMT in patients with and without diabetes. TZDs may therefore reduce the progression of coronary atherosclerosis compared to other anti-diabetic drugs. This study was designed to assess the effect of rosiglitazone, an insulin sensitizer, versus glipizide, an insulin secretagogue, on intravascular ultrasound assessment of atherosclerosis in native coronary arteries. The primary endpoint was an intravascular ultrasound endpoint, and this was the change in percent atheroma volume. There were two other major secondary endpoints. Of the two, change in normalized total atheroma volume, and also change in atheroma volume in the most diseased 10 millimeter segment within the 40 millimeter segment that was analyzed in the non-intervened vessel. Here is the primary endpoint. It was obtained in 462 of the patients, representing 69% of the total cohort. For those patients having a clinical event such that they could not have the 18-month IVUS, those patients were assigned a percent atheroma volume using a worst rank sensitivity analysis. That is a conservative way to assign a value in a patient that did not have the final IVUS. As you can see in the glipizide treatment arm, there was an increase in percent atheroma volume from baseline of 0.43. This was not a statistically significant increase compared to baseline. For those patients allocated to rosiglitazone, there was a decrease in percent atheroma volume of 0.21. Once again, not statistically significant compared to baseline. The treatment difference also was not statistically significant, with a p-value of 0.12, with an overall delta difference in PAV of 0.64%. The approach trial leads to inevitable comparisons with a similar trial called Periscope, reported at the ACC, of which I also was a co-investigator. These trials include similar patients with diabetes. There are some baseline differences in the two. The trial design is very similar, 18-month apart coronary IVUS assessments. The comparator drug treatment are both SUs. Whether or not there's difference between those two drugs as it relates to IVUS measured progression is unclear. Nevertheless, I've presented the results on the left with approach, and just to remind you, in Periscope, there was an increase of 0.73 in the glimepiride treatment arm, a decrease of 0.16 in the pioglitazone arm, and there was a statistically significant difference between the two. So in summary, compared to glipizide, allocation of rosiglitazone led to a non-significant reduction of the primary endpoint of percent atheroma volume that was not statistically significant. There was a significant reduction in the secondary outcome of normalized total atheroma volume. There was no statistically significant reduction compared to glipizide in the secondary outcome of atheroma volume in the worst 10 millimeter segment. There was no significant differences in major cardiovascular events. Hypoglycemia was more frequent with glipizide, and a decrease of hemoglobin of at least 3 grams per deciliter was greater in patients randomized to rosiglitazone. In conclusion, this study supports but does not prove the hypothesis that rosiglitazone has a greater anti-atherosclerotic effect than glipizide. in these patients. Pre-specified subgroup analyses, which I'll present at the abstract, raise the hypothesis that rosiglitazone may have a greater anti-atherosclerotic effect in patients with more advanced diabetes. Ongoing analyses will evaluate which factors relate to changes in atherosclerosis as measured by IVUS.
And discussant Beatrix Rodriguez had this cautionary take.
The findings of this study need to be interpreted with caution. These findings did suggest that rosiglitazone may be associated with a reduction in the total atheroma volume. But again, we need to be cautious with this interpretation. There was a recent consensus statement on the management of type 2 diabetes from the American Diabetes Association and the European Association for the Study of Diabetes that was very recently published in Diabetes Care, which indicated that although those previous meta-analyses and research findings showing an increased risk of MI were not conclusive, given that there are various other options available for the treatment of type 2 diabetes, this group advised against the use of rosiglitazone at this time until more research is conducted.
So to sum up, these results are essentially the flip side of the periscope results, but they don't really advance the argument of which drug to use. I'm Peggy Peck, MedPage Today.